Hi, thanks for tuning in for my presentation as a part of the International Population Data Linkage Network's 2020 meeting. Today I'll be talking about leveraging health administrative data to investigate maternal social vulnerabilities in the context of early life respiratory syncytial virus, RSV, related hospitalizations in Ontario, Canada. And this is work that I did while completing my PhD at the University of Toronto and ICES. Here's an outline for the talk you'll see today. But first, a little background. So if you're not familiar with RSV, it is the most common cause of respiratory tract infections and hospitalizations in young children. There are also substantial direct healthcare costs, and this excludes indirect costs such as parental work leave. Currently, there is no approved vaccine, but there are a few promising candidates currently in clinical trial. And until then, an immunoglobulin prophylaxis can be given to high-risk infants to prevent severe RSV-related illness. Now, this prophylaxis, called palivizumab, has been shown to be highly efficacious in preventing RSV admissions, but there's mixed evidence around adherence, which is really important for ensuring its therapeutic effectiveness. A recent Canadian study found that adherence to the palivizumab dosing guidelines tended to be greater among children who were born to more highly educated mothers and if they had siblings, while adherence was lower among those of Aboriginal descent if they had a mother who smoked and older infants. Now, we know from other respiratory tract infections, such as influenza, that socioeconomic factors contribute to respiratory tract infection risks. And this happens through differences in the risk of transmission, modifiable risk factors, barriers to accessing timely and adequate health care, and reduced uptake of interventions, such as prophylaxis. Now, to date, there have been very few studies specific to RSV. Much of the RSV literature has focused on medical risk factors, but it would stand to reason that these factors would be no less important in the context of RSV as they are for other infections. With this in mind, the aim of our study was really to address our current understanding of RSV burden and risk factors, and particularly in the context of these social factors. It was also to inform health decision-making, either through revisions to RSV prophylaxis recommendations and eligibility for high-risk groups, or for informing emerging vaccination strategies. More generally, we want to provide some insights into potential social disparities and the burden of RSV in Ontario. And to do this, we leveraged the unique data sources that are available through the ICES data repository. So if you're not familiar with ICES, it houses multiple linked population-based health administrative data for anyone that has ever had a healthcare card in Ontario since the late 80s. And increasingly, there are more socio-demographic and social administrative data that are being added to this infrastructure. And the background of this linkage, which is done at an individual level, is this unique encrypted individual level identifier called the IKN, or individual key number. Now, most of the databases, as I previously mentioned, date back to the late 80s, and they have high linkage rates. And using these data, we can identify a number of risk factors or proxies for risk factors through healthcare encounters, registry data, census data, and a number of research data sets that have been linked to these other data sources. In the work you'll see today, we used a number of covariates, and these included the child's birth characteristics, comorbidities, and sociodemographics. But because we're using this linked data infrastructure, we also have information on the child's mother if they were born in Ontario. So using this, we were able to identify a number of social demographics and social vulnerabilities pertaining to the child's mother, and I'll walk you through these on the next slide. We also were able to identify a number of neighborhood socioeconomic status factors, and you might be familiar with some of these as they're quite traditional, such as income quintile and census-based multifaceted measures of marginalization or deprivation. In Ontario, we use something called the Ontario Marginalization Index to look at this. Now, just to walk you through how we captured all of these different variables using this data, child's birth characteristics were identified through our birth registry, which is aptly named Mom-Baby. Comorbidities also through Mom-Baby, for example, congenital anomalies, and through encounters with the healthcare system. Demographics for the child were based mostly on what we call the RPDB, so the Registered Persons Database, and this includes information for anyone that has ever had a healthcare card in Ontario, and particularly things like their date of birth, their postal code, and so on. Neighborhood SES was through census-based measures such as OnMarch. Now, for maternal social vulnerabilities, we did this in a number of ways. So, for example, we looked at whether the mom had used any number of Ontario's social assistance-based drug insurance programs for low-income residents, and we did this through claims submitted to the Ontario Drug Benefit, ODB, plan. We also had information on her immigration status through our immigration registry. And now because, again, we have this linked data infrastructure, we not only know the mom's age of the current birth, but we can look back and see the age she was when she gave birth for the first time in Ontario. And this also allowed us to estimate the number of children that she has through the number of deliveries she's had in Ontario. And then using these healthcare encounters, we were uniquely able to identify either directly or indirectly some markers of severe social vulnerability. So these included transfers from mental health or correctional facilities, and then mental health and addictions admissions, so really a marker of severe mental health or addictions concerns. We were also able to identify whether she's had any recent experiences with homelessness, woman abuse, and whether the child was apprehended at birth using markers identified in these data sources. Now, our outcome was community-acquired RSV admissions. To identify this, we used an algorithm that was specifically developed and validated within the context of these administrative data in Ontario, and it uses a set of diagnostic codes. We also supplemented this for laboratory test positive for RSV that happened within 7 days of admission. We also looked at a secondary outcome, which was RSV admissions and lab-confirmed emergency department visits. So this allowed us to look at a broader range of severity and illness, and in a lot of places, emergency department visit data is not widely available. So this was really a unique contribution that we were able to add. Now, just to show you where these data were derived from, so the newborn admissions you might have seen on the previous slide were an exclusion. So these came from the birth registry and also health encounters. Inpatient admissions were through our discharge abstract database. Emergency department visits through our national ambulatory care reporting system. And then interesting laboratory data were taken from a research cohort, which included a whole host of pediatric hospitals, adult hospitals, and our provincial laboratories. And these have since been linked to the ICS infrastructure. So this allowed us to look at laboratory data which would not otherwise be available through these health administrative data. So the study period included fiscal years 2012 through 2018. And we included follow-up until the end of fiscal year 2019. So as you can imagine, this work was done a few months ago. So these data were quite up to date at the time that they were done. And RSV admissions were identified before the third birthday or the end of follow-up period. Now, our study outcomes and results, I won't get into too much detail. If you're interested in hearing more about the epidemiological side of this work, I do ask that you reach out and we can chat a little bit further. But in essence, our outcome was the occurrence of the first severe RSV-related illness, hospitalization, and we looked at 2 measures of association. Now, our cohort included nearly 800,000 children, and of these, nearly 11,000 had at least one RSV admission before their third birthday. So again, in brief, our first major finding was that many social and social demographic characteristics were independently and statistically associated with RSV-related hospitalizations. So to provide a few examples, children that were born to teenage mothers were 50% more likely to be admitted with RSV at least once before their third birthday, relative to those born to moms aged 25 to 29 years of age at birth. And this is adjusting for a whole host of factors you see on the bottom. So these are factors related to severity of illness, transmission, eligibility for prophylaxis, and so on. We also saw similar associations when looking at multiple maternal social vulnerabilities. Our second major finding was that statistically significant reductions in RSV admissions could be achieved if we could somehow eliminate these increased risks associated with a number of these social factors. So if we could somehow eliminate these risk factors through prophylaxis, vaccination, or something else. Here are a few to highlight, and I'll just walk you through one of these. So for example, if we could somehow eliminate the increased risk of RSV admissions experienced by children who were born in lower income areas, or somehow make it so that their risk is similar to those children that live in the highest income areas, we would expect to see 7% fewer admissions for RSV. All right, so this might be a little bit more interesting to some of you watching this. So a few methodological considerations. So we do not have data on whether the child actually received the RSV prophylaxis. So this is going to be really important for determining, are these social inequities arising because children are eligible but not receiving them, or is there something else going on? And also to note that we didn't have all of the information required to fully identify if the child was eligible for prophylaxis. So we did have a number of this information. However, things like daycare attendance are included in our RSV guidelines, and this is not available through health administrative data. And just to note that there were some legal issues with data sharing, which are currently being worked out by others using this data. There is also limited information on social demographics and other characteristics we'd want to include. And just to note that we're going to underestimate these social vulnerabilities from health administrative data. So unless a woman is being transferred from a mental health facility or a correctional facility, she's probably not going to admit to her doctor that this is an experience that she's had, because it's highly stigmatizing. So really what we've captured is an underestimate of the true social vulnerabilities that these babies and mothers have experienced. There are also other factors we'd want to include. So as I've previously mentioned, something like daycare attendance, it's outside of this administrative data. And then for some other things, there were concerns around underreporting. So one of our data bases includes information on whether the mother or anyone else in the household was smoking tobacco during pregnancy or shortly after delivery. So obviously this is something that not a lot of people are going to admit to. So again, this is underreported. And then for some of the data that we have available, there are special permissions and governance structures in place, such as those for the Indigenous identifiers that we have at ICS. So they were not yet included in this work. So what are the takeaways? So in practice, this work shows that there are probably some social inequities in the combination of transmission, severity, or uptake of preventative measures against RSV. And this is within the context of our publicly funded healthcare system and a publicly funded prophylaxis program. And it has the potential to directly inform healthcare decision-making, so either in revisions to our prophylaxis program or emerging vaccination strategies. But more generally, it highlights the need to ensure that both medically and socially at-risk children receive adequate preventative care for RSV. And from a research context, we've shown that you can leverage these health administrative data to uniquely identify social vulnerabilities that would not otherwise be available through these data directly. And we can do this using proxies, such as the use of low-income drug benefit claims, or directly, such as transfers from various institutions. Here are my references in case of interest. And I'd like to acknowledge my co-authors, data provider, and funders. And if you're interested in hearing more, please reach out and we can chat further. Thanks for listening.